And then in terms of duration and class of antibiotics, they only found support for use of macrolide antibiotics specifically. So you could take that with a grain of salt. That's just for the evidence that we have.
And what do you do with your practice?
So from a clinical experience, I do tend to do the 3 weeks of antibiotics, culture-directed. And in terms of the steroids, it just depends. If there's a lot of edema that I see on endoscopy, then I will give a course of steroids on top of that.
And how long?
It depends. So if it's obviously if it's someone with nasal polyps, then it's going to be a longer period of time. If it's something like this type of situation, I don't think 5 days is unreasonable. A week, Medrol dose.
Greg, anything to add to that?
There was a study, I can't remember if it was Tim's study or not, that looked at the cumulative dose of prednisone and the incidence of lawsuits, avascular necrosis being the key. Pecker? Oh, yeah, it was David.
Avascular necrosis of the hip,
right,
as an idiosyncratic result of high-dose steroids.
Correct.
Okay.
And we need to look this up. I think it's like right around 250, 280 milligrams of cumulative prednisone dose. So if you do 30 for 4 days, 20 for 4 days, 10 for 4 days, it's below that. Doesn't mean nothing can happen. It's just there were no published lawsuits in the Westlaw database. When you go above that, there are some litigation. So whether or not we should let litigation drive our medical decision-making is a separate question. But to be safe, I tend to use that 12-day course because of that.
Let's go to the audience. How many here use steroids routinely as part of their preparation for defining maximal medical therapy? Who does not use steroids routinely? Ian Humphreys, can you share with us your thoughts about that?
I tend to go with what Jimmy already said too, in terms of the IFAR guideline, or consensus statement rather. If the patient has polyposis, then I will use prednisone in the manner that Greg described, for 4 days each. Typically with oral antibiotics in that setting, the top use of steroids greater than 18. If there are CRS without polyps, then I would do 20 days of macrolide with secondary steroids, unless there was concomitant asthma or some other factor.
So you're a believer in the IFAR 300-page consensus statement that...
That's the evidence we have thus far, and I think there are...
I'm glad you said I'm actually one of the co-authors, so thank you for saying that. I wrote like 2 lines in the pediatric bit. I think that the macrolide challenge is interesting here. Does it really matter then if we're doing cultures? If that's the recommendation, does the culture influence things? But that's... GAVN, what do you think? Is the culture a waste then? Should we just be doing macrolides?
No, I don't think the culture is a waste. I think, we just don't have, you have to remember that was an evidence-based review, so there just hasn't been trials specifically focused on culture-directed antibiotics, but intuitively you would imagine that should be useful. The reason why the macrolides have gotten so much attention is because not only do they have antibacterial properties, but they have anti-inflammatory aspects as well, and that's why it's believed that they have such good efficacy for the CRS without nasal polyp group.
Before we move on, I just want to tease out one little thing here, is that what about additional concomitant therapies that we've been hearing about in the last decade? What about shampoo? What about Manuka honey? Have those become popularized enough that we have evidence to say those are this intelligent audience here should be using that regularly in practice? I see angry Kevin again. Angry, go ahead.
I'm cooling down. No, I don't use those or recommend them. But just to go back to the culture thing, I think a lot of us here, including myself, have cultured patients and started them on antibiotics because you think you know what's going to happen. Then 3 days later, you call the patient and say, oh, you're growing out Pseudomonas. You need to stop your Augmentin. I'm going to send Cipro. And the patient says, well, I'm feeling better at this point. And then there was a paper just out of Stanford where I think it was Stanford, where they cultured people and they put people on empiric antibiotics versus culture-directed, and there was no difference in the outcomes. So clearly there's something not going along the lines of what we think cultures are doing for patients, and whether that has something to do with the microbiome, or whether we're just culturing the wrong stuff, or there's some other effect of the antibiotic.
Or that now we're controlling enough of the inflammation that's really the issue, that we weren't doing a very good job of controlling the inflammation, and just that is letting any antibiotic create an improvement.
Yeah. So I want to ask Chris, since he's here, we have the European position statement paper. If you look at their antibiotic statement, they're a proponent of doxycycline. So doxycycline was compared, there was a randomized trial versus prednisolone, I believe, and then a placebo, and there was a significant decrease, the same as prednisolone with the doxycycline cohort. So what do you do in your land over there?
Doxycycline. Yeah.
Can you introduce? Would you mind introducing Greg? Greg, could you introduce Chris? That'd be really helpful.
I'm a Brit. I come here a few years. Every friend of Doug. Facial pain, we say eyes, sinuses, and teeth until proved otherwise. You've got pus coming out of a sinus, but the pain's up here. So we tend to say start them off on some medications because you need to know about compliance. Has this kid actually done it? You're saying she has. Long enough and strong enough is a good ploy. Probably, if they've done that, going for CT sinuses. But we'll just send them along to the laboratory, do IgE and a RAST for inhaled allergens. Have you been to your dentist? Yes, no. Have you been to the optician? Yes, no. What's her social history? Is this headache? Is this migraines plus sinuses? Is this multiple pathology? Children tend to be monopathology. Teenagers seem to be a pain in the ass. But you got to try it. But at the end of the day, you've got to image.
Yeah. Okay. Anybody else have any questions before we move on to show? I'm going to show you the imaging next. Anybody else? Anything else to add? Okay.
Just want to make
Go
one
ahead.
note. I mean, you have this culture here, and she's been on multiple antibiotics, and it shows abundant strep in there. So you may want to think in the back of your mind, especially if that CAT scan is positive, to assess her immune system to see if she has, does not respond to streptococcal challenge. So just something I always keep in the back of my mind for people who start having recurrent infections.
That's a great point. I mean, I think of this as more as an adult at 18, but certainly when I see children that have recurrent rhinosinusitis, it's seldom we operate on them, and I'm always thinking about the red flags. Do they have recurrent pneumonia? Do they have a history of otitis media? Are they healthy? Are they having low delay? Then we'll do a deeper dive into these other arenas, looking for rare things, immunoglobulin subset deficiency, looking for HIV, looking for cystic fibrosis. Those are rare things, but that's what we'll think about when we have younger kids that have these chronic problems. Okay, let's look at this imaging here. So this is our patient, and it was the patient actually came with their scan already. It was a second opinion, and this is looking at I have a few images to share with you. Here we have, and by the way, there's no tricks here, just for the panelists and for the group. There's nothing tricky here. This is a scan. It shows a deviated septum. There's some mild inflammation in the maxillary sinuses, the ethmoids, and here we're looking at the axial. You can see the severity of the deviated septum and some inflammation. And here we're looking at more in the ethmoid area. And there's some disease in the frontal area on the right side, perhaps a little inflammation on the left. So we have an 18-year-old girl, healthy, with chronic rhinosinusitis, and it's hard to say, would you say chronic recurrent or chronic rhinosinusitis in this case, but somewhere in the area chronic without polyposis and plus a deviated septum. Let's see I'll go through those images again just so you guys can see them again. There's the ethmoids, there's the septum, there's the coronals. Let's start with Arif. What would you do next?
I think that we see some obvious access issues with the nose and then some degree of patchy disease, nothing that is super striking. I'm interested in what's happening at the base of the maxillary sinuses there. I don't know if we're simply seeing some mucosal change at the floor, or whether we're seeing some evidence of periapical changes around.
Assume it has nothing to do with the teeth. Let's not go down that path. So.
Okay, and so pretty mild disease here. I'd be surprised. It would strike me as difficult to believe that this patient would not get better on a very appropriate course of oral steroids and prolonged antibiotic therapy.
Yeah. And
something doesn't fit.
What do you think about the septum? And how does that? Where are we right now with our understanding of deviated nasal septum and being prone to rhinosinusitis? What are your thoughts, Arif?
I mean, I think we all have the thought about there being a space issue that is going to predispose us to having some kind of issue with recurrent infections. And I haven't quite gotten from her history whether she is a recurrent versus persistently chronic in terms of her symptoms. I find it hard to chalk up chronic symptomatology to a septal deviation like that without evidence to that fact, meaning that we don't see a ton of circumferential mucosal thickening within that maxillary sinus. To me, this isn't something that I get very poor or recurrent repeated obstruction of that right osteomeatal complex. And so although I believe that it creates a space issue and a ventilation issue of the middle meatus on that side, I'm not sure that her symptoms and the remainder of her CT scan go along with that.
David, what do you think? Do you think that having a deviated septum that you don't know about, predisposes one to recurrent rhinosinusitis or chronic rhinosinusitis? What are your thoughts?
Probably doesn't help, but in my mind, if they don't complain of nasal obstruction, I'd probably be hard-pressed to say, yeah, we got to straighten that septum or else. Now, if I decided that I was going to do something surgically, then I would probably address the septum at the same time. But for as far as like just a hard and fast bent septum, recurrent acute, definitely got to do something. No, I wouldn't say that I have a rule like that.
Would you offer this patient surgery?
I know that I just gave the lecture on it, but like this is actually not a terrible patient to try balloons on. I think fairly limited disease. Depending on if she'd be able to tolerate it in office, you could even consider it there. But if I were to offer surgery, it would be either that or a very limited endoscopic sinus procedure addressing the maxillaries and anterior ethmoids. I didn't see a lot in the frontals. I guess we didn't get a real good look at it.
There was some mild schmutz.
Schmutz.
Right there, just in that sort of more to the anterior, but it wasn't.
Is she hypoplastic on the right side? Because Greg and I were sort of, where's the rest of the frontal on that? Is there any other?
Let's just. I know the images and the answer is no. She's not hypoplastic.
So she has otherwise normal frontal sinuses.
Correct.
It's just that little bit at the
Yes,
bottom.
some mild inflammation in one pocket on the right side, and a little bit on the base on the left. Jivian, what do you think? Is this
Her
patient
main symptom is frontal headaches.
frontal and top vertex headaches?
Sorry, I meant to ask you about that. Did she have any issues with photosensitivity or nausea? with
No,
that? Okay.
no. So is this patient a surgical candidate for you, Jivian?
Yeah, I think this is your typical challenging patient where the symptoms don't exactly match the CT findings. And you can certainly offer to this patient, but they have to understand, and their family, that her symptoms may or may not necessarily improve with surgery. And I think that's really important to highlight because her primary issue is frontal headaches, and she really doesn't have any frontal disease. Even if we were to do a limited FAS, I'm just not sure if it's actually going to get better.
So by the way, I love that you're saying, because it's such a part of my practice, this arena of shared decision-making with families. I've really adopted and embraced it in this decision-making. There's no more a sense of a recommendation. It's just just sharing what I think is going on and that the chances of maybe improvement may not be. It also makes me feel better when we don't make improvement, that hey, I've set the expectation bar low enough that I can achieve it, and if I don't, the expectation is low, then I'm okay. Because how do we not know this is some variant of migraine and that we're seeing some other option, but the patient's having pretty low quality of life, and so we share the options, the risks of the surgery, and we move on. But I'm going to give 3 options now to you, the panelists and the audience here, about our 3 options. So one would be in-office-based balloon sinuplasty. The second would be OR-based endoscopic sinus surgery, and the third would be watchful waiting. So those would be our 3 options. So we'll go option 1 for in-office balloon sinuplasty. Who's going to choose that? Who's going to choose endoscopic sinus surgery for this patient? And we have a handful. And who's going to pick watchful waiting? Interesting. So the family picked endoscopic sinus surgery, and she underwent bilateral endoscopic anterior ethmoid X-ray, like you were talking about, David. Would anyone here, if they're going to do surgery, would anyone do sphenoid or frontal sinus surgery in this case, in the panelists? Based on the frontal sinus. Greg, you have a thought? Or no, go ahead, Arif.
If I was going to take this patient to surgery, and the reason I said about watchful waiting is I'd put up a couple roadblocks or hurdles, which are that we should investigate her immune system and whether that's playing into it. And then part of the shared decision-making around this, are these headaches really sinus origin? Maybe we should get one of my headache colleagues to examine what the temporal sequence is and create a headache log. It creates some hurdles to it. And if after all that, we have the shared decision-making that we can undergo surgery, with the expectation that this may or may not improve your headaches, then if I did it, I would, yes, completely address those frontal sinuses to the extent that we want to make sure that the symptomatic areas are well ventilated and stay patent postoperatively. And so I would not, and sphenoids, no, not something that I saw either diseased on the scan, but I will say that the entirety of that osteometal complex, maxillary, anterior ethmoid, frontal, should be ventilated.
You would do the full, yeah. You would do agonizi. Okay, Greg, what are your thoughts? If we decide the family's aware of the risk benefits, alternatives, feels motivated to do something because they're just tired, what would you offer surgically?
So surgically, first, I would also offer the headache clinic as an option to do before surgery and plant the seed that surgery may help, but you may need this after surgery as well. I think that's a very good recommendation, Arif. This patient needs a septoplasty in order to get into the right frontal system, so you'd have to do a septoplasty in order for access to that. And then I would do the frontal, ethmoid, and maxillary surgery. But I think this comes down to your comfort level. I think there is a decent chance that doing a mini FES and maxillary and anterior ethmoid on that right side is going to help out her frontal symptoms. So if you're not super comfortable with the frontal sinuses, then don't do it. Don't make it worse. But if you are comfortable, there is disease. We have established the diagnosis by endoscopy and by CT scan. We know she at least has CRS without nasal polyps. She's failed appropriate medical therapy, and sinus surgery would be very appropriate for her.
Kevin, if you were going to do surgery, would you do everything?
I'd do everything. The reason why is that CRS, if this is truly the case, is a dynamic process. And if you do serial imaging of people over time, which I've done for people who have not opted to have surgery, you can see changes in the degree of mucosal thickening and the degree in each of the sinuses of that mucosal thickening. I've done mini FES on people only to have them have problems later on in sinuses before that never had problems. And I know Peter Wong and the Stanford group came out with that paper recently about comparing full FES, I guess, with partial FES, and the outcomes were the same. I have no reason to disagree with that conclusion, but my personal experience in following people over time, and frankly, to a family or to a patient, I don't like telling a patient, well, we have to go back and do it again, So I realize there's extra risk, but in this case, you're doing the frontal, you're doing the maxillaries, you're doing the ethmoid, but not the sphenoid. So I see little harm in adding that.
I think that I chose to just do anterior ethmoidectomy, and by the way, when I do a complete anterior ethmoidectomy, you've got the frontal hanging out anyway. But it was a limited FES with maxillary sinus enterostomies and ethmoid. And I hear your point about you don't want them to come back. On the other hand, I think I still think of this as a functional procedure. That we're just functionally improving aeration of the area. In this case, I was able to manage things without doing the septoplasty.
If it's a functional problem.
If it's a functional problem, yeah, that's a good point. If there's not a systemic issue that's underlying it. Anyway, I think you guys have done a great job of highlighting the controversy of these cases and where we are in our field. The septum to me is also challenging. When is it, when an asymptomatic patient, is it appropriate to do septoplasty? And I think it's just when there's an access issue for my practice. I don't know, does anyone have thoughts otherwise? If you have a asymptomatic deviated septum, do any of you routinely correct that for this purpose of improving sinus function? Does anyone in the group feel that way?
I do for improving sinus access. My ability to do a good job and my ability to surveil postoperatively is that much better. If I think septum, I do septum. If it ever crosses my mind,
If I think septum, I do septum.
I have a very low threshold because I think that our ability to do a good job at sinus surgery and in the office afterward is that much better.
Interesting. Jivian.
Yeah, I would have to agree with the Reeve, especially when you're doing the frontal recess dissection. Doing the septoplasty is very helpful. And the reason for that is when you're trying to uncap the auger and so forth, if you can just push the septum, out of the way, and it's so much easier for access and for the debridement postoperatively. So I have a pretty low threshold for doing septoplasties too.
Let's go to the audience. For patients you're already doing sinus surgery on, if they have a deviated septum and asymptomatic, but it improves your access, do you routinely perform septoplasty? Does not routinely perform septoplasty. There you have it. So it looks like sorry, sir. You look happy though. Thank you. Any questions about that? And it's a straightforward case, but there's so many facets that are interesting.
I was just going to ask, do you bill for septoplasty when it's for access?
The question is, do you bill for septoplasty when it's for access?
So technically you can't.
But do you bill for septoplasty for access? And how about Team Canada here, Arif?
Yeah, I work in Canada. If you do it, we bill it.
Yeah. Jivian?
I just dictate it, but I don't really know what they're doing after.
Your coding is out of your hands, is it?
Yeah.
Yeah, it's
So
great.
one of the main symptoms of CRS is nasal obstruction and chronic congestion. you have a patient with CRS and a deviated septum, I mean, there are ways you can sort of figure out which of those components are contributing to the nasal obstruction and the nasal congestion. So when I take a patient to the OR for chronic sinusitis and whatever other issues they're having, my goal is to achieve the best outcome and quality of life for the person. So if that's getting rid of their nasal obstruction, and if that involves reducing their turbinates or straightening their septum and doing their fess, then I've helped that patient, so I will bill for that. But if I've decided in the middle of the case that I'm having trouble getting up into the frontal and I have to cut out a little wedge of the septum there just to get that access, I'll dictate it, but I typically won't put it in the procedure as a billable procedure. Of course, I dictate everything that I do, but won't bill for those things. So if it's strictly for an access, I don't bill for it.
For strictly CMS reasons, I think we're not supposed to bill septoplasty if it's strictly for access. I think that's in the CMS coding. So it's a caution to bill it concurrently unless there's actually evidence of symptomology. Would you all, I see all agree, you seem to be agreeing with that. Greg?
Yeah, and that's just, as Kevin's saying, if they have nasal congestion, if this patient's going to have some nasal obstruction, if you ask them, the odds are. And it's how you word it in your dictation. I mean, you're doing the work. You should get paid for what you do. It's extra work. You're improving the outcome of this patient by doing so. There's no reason not to get paid because of a technicality that CMS put in. So if you put in your op note, I did this to improve access to the frontal sinus, your coder may not code it, or they probably shouldn't. But if you said, I did it because it's a deviated septum or nasal congestion,
That's
you're going to
good.
get paid.
That's good
And you should
logic.
appropriately
Yeah,
get
that's
paid.
the same reason I bill sort of skull-based eradication when I remove adenoids. I don't know. I have trouble with that too because I mean I think the CMS guidelines are pretty clear. I think it's a fine line. So it's a personal choice. Pardon me?
The approach as well?
The approach and the excision of the skull-based lesion when I do adenoidectomy. It's going really well for my career.
To me, this is seeing that septum, that's a moot point. That is a septum that needs to be done for a whole host of reasons. Whether, I don't know what symptoms you need to hear from that person, but that septum needs to be fixed. I have no problem getting paid to fix it.
Okay, let's move on. We've beaten that horse. Anisha.
Just a question about the timing of a CT in terms of level of symptomatology. Is that something that's important? Timing with respect to when the patient gets it in their medical treatment? And then a follow-up question would just be what were intraoperative findings?
Oh, okay. So I'll address a second. And what were my intraoperative findings? It matched the CT. So there was mild inflammation within the sinuses that I explored. So it was concordant. So the second question was regarding about the timing of imaging with regards to sinusitis, and I guess it relates to whether you're going to give antibiotics or not. So in this case, if you're going to treat it again, and do you think that when you see a patient with rhinosinusitis and you're going to treat them medically, is it advantage to have pre and post imaging, or do you think you want to do your treatment and then do imaging afterwards? Jivian, I'll let you start with that one.
No, I think this is pretty controversial, whether you do a point of care CT or you wait after medical therapy. I think the traditional teaching has always been to not necessarily get the CT during the acute infection, but you want to see if the patient responds to medical therapy. So it kind of depends on where you get the patient. Now, if the patient's already had multiple courses of antibiotics with their primary care doctor that you feel would be appropriate medical therapy, then I would just go ahead and get the CT scan at the time of the initial visit. But if you're planning on still trying your own round of medical therapy and see if it's effective, then it wouldn't really make sense to get it right away. You want to see if the patient responds, and then we get it a week after the medical therapy is finished.
I think there are certainly a large number of scenarios that you can think of, but I think of two primarily. One is getting a CAT scan in the setting of a negative endoscopy, because if my endoscopy is positive, I know they have disease and I'm going to treat that disease. So if it's negative, the next question I have is the timing of the symptoms. Because if they're coming in with recurrent problems, they come see me and they're feeling happy and lucky, and I scope them and it's all negative, there's no point in my mind to getting a CAT scan at that point. But if they're coming in symptomatic and the endoscopy is negative, then that is a great time to get the CAT scan. And there were a couple studies done out of Northwestern where we evaluated the cost effectiveness of doing that, as well as the effectiveness of reducing unnecessary antibiotics and consultations. And doing point of care imaging at the time of negative endoscopy in a symptomatic patient was very cost effective and avoided a lot of unnecessary treatment. I did a study back at Loyola where we just looked at the number of symptoms. And if you had a negative endoscopy but few cardinal symptoms, there was no role for a CT scan because they were all negative. So I think as to what Jivianne said, definitely, in the context of post-treatment, or if I'm thinking about surgery. Because if I keep seeing a patient back and they're not getting treated, they're being treated, but there's no resolution, but I still see pus, then I'm still going down a treatment algorithm. And then if I'm thinking surgery, that's finally when I'm usually getting the scan.
Chris, why don't we let you close off on that dialogue?
One symptom that you haven't really addressed is pain. What do the panel, or what would you do for a child or an adolescent to control one of their main symptoms is pain? What analgesics? Sometimes we use medicines as a part of our diagnostic process. The paracetamols, non-steroidals, amitriptyline, those sort of anti-migrainous therapies.
Yeah, I think I picked more along the rhinosinusitis pathway rather than pain pathway because of the endoscopic findings. But that's a good question. Does the team have a routine pain analgesic standard that they use for their patients? David, do you use analgesics routinely for the treatment of your patients?
I wouldn't do anything that was heavier than over-the-counters for this patient, and I would also be loath to offer anything for migraine without having them see the headache people first. I personally don't feel comfortable managing migraine just because I feel like that'll put a neon sign over my door, and I would rather get someone else involved who can direct those things for me.
Anybody else have anything else to add to that? Okay.
Did your vertex pain go away after surgery?
Oh, I cured her. She's perfect. Yeah. This case is only a few months old, so I don't have long-term follow-up. But my first post-op visit, she's doing well. She's still going through recovery. So I'll, maybe when you come back to the course next year, I'll give you an update on how she's doing. But I think based on the findings, I'm excited about her because of the fact we actually found concordant rhinologic disease at the time of surgery. So I'm sorry I don't have the long-term follow-up. Okay, so let's look at. I was going to split you up into teams for the rest of the talk here. We have a handful of questions. David, I'm going to put you on. Which team is weaker here? I'll put you on that team. Whichever team Greg is on. Okay, so you're with Jivianne, you're on team A, and Arif and Kevin, you're on one team, and there will be scores, and there will be prizes, or maybe not. We'll see. Okay, so please complete. There's a handful of statements. You have to complete them. I keep my middle turbinates from lateralizing after ESS by, and I want to hear. Let's see. And the audience is going to. Hopefully, you guys have some different answers, but let's see. Let's go with Kevin on this one. What are you doing now to prevent middle turbinate lateralization after ESS? Anything.
I suture the middle turbinates.
Arif, you're on his team.
If I have a septal surgery and I'm going to quilt the septum, I suture the turbinates through and through, and so I keep them together like that. And I routinely use silastic stenting in the middle meatus after sinus surgery to prevent middle turbinate lateralization, amongst other things.
Jivianne, for Team B, what do you think?
It's funny because someone asked me that in the cadaver dissection, and I don't think I've really found like a perfect solution to prevent them from lateralizing, truthfully. I end up going back to the finger glove mirror cell, and we have a whole host of things that we can use.
Finger glove mirror cell.
That was sort of the traditional pen thing
yes.
that we did.
And hopefully latex. Hopefully latex.
Yeah, and the funny thing is, I always try all the newest things that come out, and I've used the Propel, everything, Nasopore, but I always end up going back to that because it just really medializes it so well.
Which glove are you using?
Just a size 6 glove, the pinky, then you just sew it.
Yeah.
Mirror cell.
Okay.
Yeah.
All right. Good.
It's pretty old school,
good.
I know.
Yeah. Good.
$19.
Yeah. And it says, well, I mean, I was just joking about latex because that can provoke a foreign body reaction. So, Greg, speak for the weak team.
For the A team, the A team likes to use the steroid-releasing stent, and it's just so easy.
Routinely in your practice.
No, if I'm worried about
okay.
lateralization. Yeah, definitely not
Okay.
routinely, but
So
lot.
it's-
I'd say
yeah.
plus 80% of my patients have inflammatory sinus
So
disease, too,
far,
it's
all
a 2
four,
for
it's
1.
good all four of you have agreed so far. Okay, go ahead, David.
What should have gone before Greg, because my answer is the same. And well, my first answer is the kind of cop-out, it depends. If I think that the turbinate looks like it's likely to lateralize, then my favorite thing to use is the steroid-eluting stent. But if I don't think it's at a big risk of that, then I do nothing. And sometimes I'm sad about that.
So in this case, the right answer is what I do, which is the middle turbinate through the septum suturing. And I've just started doing it recently, and I'm happy with the results. So, Arif, congratulations. You got the answer right this round. Okay, next statement. I absolutely love and can't wait to use in-office balloons in my rhinology practice for. And David, you're going to go last. Kevin. You just love it, and you can't wait.
Opening my postoperative stenotic frontals and sphenoids.
Okay. That's a good answer. Arif looks like she's in agreement. Team B's got concordance. Okay, Jivian.
That's what I would.
Jivian.
Team A has concordance with Kevin. God, that's when I use it the most, post-op frontal ostium stenosis.
So, okay. Greg.
I'd love to use it for recurrent acute sinusitis. I just don't get those patients too much. And they have to have a straight septum, too. Your last patient, there's no way I'd try a balloon sinus dilation on that, not in a million years.
David, when do you love it?
I'm actually not that good of a person to ask. I don't do a ton of these, despite having given the talk about it. But the patients that I choose, I've done, I'm hesitant to even confess this, but I've done 4 in the last year.
David took one for the team on that. Thanks, David.
Of the 4 patients that I've done, 3 were octogenarians that I didn't think would tolerate a general anesthetic very well, or the lady with Behçet's disease that I thought wouldn't tolerate general anesthetic very well. And one was a patient who just really didn't want the general anesthetic and had a limited odontogenic sinusitis. So I used one of the balloon devices and then flushed out the sinus. And then 2 weeks later,
I'm going to guess the audience may have more experience than the 5 of you Utes. What do you guys? Who else? What do you love it for? Who has an opinion about that? Is anybody here using in-office balloon sinuplasty routinely in their practice? Dale, when do you love it?
I think for like minimal disease, patients that aren't getting better with maximal medical therapy, and it just doesn't look like the disease is like everywhere.
Is there an age group that you love too?
I've been finding that elderly patients just seem to do really well with it.
Okay. Well, the correct answer is we don't know yet, but I'm going to give the point to Team A because they just need some help. Okay. Let's go next question. So it's tied. All right. Please complete this statement. If you want to surgically improve nasal air flow through inferior turbinate surgery, I would recommend to you that. Greg's nodding. Greg, go ahead.
Be gentle.
Be gentle with it.
Gentle. Having been an expert witness for a few ENS suits and helping with that, it's scary. It's a scary world out there. And I used to do it in the classic way, trained in Adelaide, and now it's much, much less. I'll use type of energy.
What do you mean classic versus how's your practice pattern?
Lateral inferior turbinate resection is really what it was.
So removing conchal bone along with mucosa was your standard.
Yeah, the lateral
mucosa.
Yeah. And so now I'll just tunnel it and do coblation, and then with an out fracture.
Coblation out fracture. And what was the why? What was this change? What did you hear or see?
Really, the change came from the litigations that I was a part of. And again, I hate the fact that changed my practice, but there's potentially something to that. And patients do really well with this less invasive technique as well.
Arif.
Be careful, less is more, and you get quite a bit with just out fracturing inferior turbinates. And for me, I stent them. I'm a big fan of postoperative stenting, and so creating that lateralization of the inferior turbinates, you can get a lot.
What are you stenting with?
Silastic that I shape into the shape of a J or a U that keeps the middle turbinates lateralized and the septum squished. Because presumably I'm doing it in the setting of a septal surgery.
So the inferior turbinates too, you address with,
If I'm going to,
You put in-
out-fracturing and
yes,
stenting is
you'll
enough.
stent as well.
And it's very rare if I do anything else. And if I do anything else, I'll make sure that I leave the mucosa alone. So it's all done submucosally. So submucosal resection with an inferior turbinate blade, something like that. But it will all be submucosal.
Javienne.
Usually I do the submucous resection with the turbinate blade, the microrepeater. It seems to work pretty well. They've had some meta-analysis, comparing that with some other techniques, and it seems to have very good long-term outcomes. So that's what I've been doing, plus the out-fracture.
David, then Kev.
I am a disciple of the same Messiah as Greg. So I also did the lateral turbinate resections. And actually, my fellowship director would routinely excise all inferior turbinates that he encountered. So basically,
Resected, just
resected,
removed,
down
yeah.
to the nub.
Yeah.
And never had a single instance of empty nose syndrome. And so you can, the group from Stanford.
Just like I've never had a tonsil bleed.
There you go. Yeah. The group from Stanford just published a paper, I think just a couple weeks ago, about the arid versus humid environments and that impact on empty nose syndrome, and found no connection based on the environment. So you can't chalk it up to just the humidity apparently, but maybe you can chalk it up to the Kiwi personality. But since talking to Greg and being a little bit more scared in practicing in the United States, I've also limited my practice more lately.
Kevin.
My recommendation is that you stay in the submucous tissue, whether you're removing tissue or bone or both. But admittedly, I've gotten, I think, more conservative over time. I think most of it was prompted, a year and a half ago, I was in Cuba doing lectures, and Brent Sr. gave a talk on turbinate reduction. And then following that, Heinz Stamberger was supposed to give a talk about some skull-based thing, but he took the first 10 minutes out of his time to open up another lecture and talk about how turbinate surgery was bad. So he felt very passionate about that. But I would definitely stay in a submucous plane, whether you're removing tissue or bone or both.
Okay, we have some good, sorry, go ahead, Javienne, and then I have some questions.
I remember though when I went to Australia and with Richard Harvey, I saw that they're really aggressive with their turbinates. It's like you were describing. I mean, I was pretty shocked.
Yeah.
It's basically a partial turbinate resection for all their inferior turbinate surgery.
It's almost like total.
But they don't have any cases of empty nose. That's why they believe that it's psychological and it's just an American problem. That's what they kept telling me. But I was
A lot of
curious.
Americans.
Two questions. So we have three questions from the back. Let's go to the middle first. Sorry, I don't know your name. Yeah, I do. It's Joyce.
Any comments on submucosal cautery versus Coblation?
Any comments on submucosal cautery versus coblation?
You mean with like a long needle using a bovie? Well, I used to do that in residency. And I think there were cases where if we weren't exactly careful, you would burn the vestibule with that. I don't know if it's more or less effective than using the coblator as a mechanism, but I think using the coblator certainly helps you avoid that. I mean, if you do tons of cautery, then you probably don't have a lot of injuries, because you
Guard it with a red rubber catheter.
That's true. But I don't know if there's any difference.
Dale and then Mark. Dale.
Yeah, with the microdebrider, does anybody really think you're taking bone out?
No, you have to
No,
make
it's
an
just soft
incision and
tissue.
then, yeah.
It's mostly soft tissue. But if you want to take credence into that meta-analysis, they did compare radiofrequency cautery and submucous resection. And even though the 6-month outcomes were the same, the 1-year and 2-year outcomes were superior for the submucous resection. But you can take that with a grain of salt. But that was the reason why I switched to do that exclusively.
But is the microdebrider actually getting bone out?
No.
Then it can't be billed as a submucosal resection.
No, it's just
So you
removing
have to
the
make
soft
that
tissue.
incision and then elevate and take out bone with some kind of forceps.
So you guys routinely do both, or just remove the soft tissue?
If I do a submucous resection, I make an incision in the head, I elevate medial and lateral, take out maybe the anterior 1/3 of the bone, and then use the microdebrider for the soft tissue.
And Javienne?
I just do the soft tissue.
Soft tissue, yeah.
I think it bears reason about figuring out what the problem is. We see people with inferior turbinates which have a huge bony component as opposed to the one that has a big soft tissue component, and I would tailor it to exactly what we see on scan.
That may be the smartest comment I've heard. So that wins the point
Yeah,
right
but would
there.
you do a CAT scan
I-
on somebody who just needed a turbinate reduction?
I think
No, so I'm not talking about-
I think we don't. Well, I don't look at scans enough to really assess. There's so many different forms of inferior turbinate. There's different pathology for. So who was just talking about this? Ian was just sharing with me some great. Ian, you want to share what you just shared with me earlier today that I thought was really enlightening? Oh, panel. Okay, let's not steal it. Okay, Mark, and then we got what? Let's go.
May we hear just a little bit more from Dr. Davis about the case that he was involved with?
Cases, several cases. So I was just asked to be an expert witness about it. Well-minded surgeons doing inferior turbinate septoplasty work. Patient had a bad outcome, sued their surgeon.
And you type
For
it in
a bad
on the
outcome.
internet, and it's the first thing that comes up. You guys are in a very difficult position because you're just trying to help, and you're a setup. You're a sitting duck. If you did anything to that turbinate that could be construed as...
The key things that come out of this litigation, and again, we're going to have a whole panel on it tomorrow, but your consent form should discuss the potential for a dry, crusty nose. You don't have to spell out empty nose syndrome. You should get consent for a turbinate reduction. That was one of the problems with one of the lawsuits. They did a septoplasty. Oh, by the way, this turbinate looks big. I better reduce the turbinate. Never got consent for that. So
Okay.
that was a second issue.
So Team A has 1 point. Team B has 2.
I sense a Canadian
Okay.
bias.
In the last year, the instrument technology that has really been a great addition to my and let's move along quickly. 1 word or 2 words. In the last year, something new you're using in your endoscopic sinus surgery that you're like, wow, that's been really fun. David. And if you have nothing new, you can point to something from years ago that you like, when you were a resident or something.
I was actually going to say, and it's not for my operating procedures, but I was going to say that my in-office procedures have benefited most from that tetracaine ointment. That has been the most useful thing that I've used for my in-office procedures, whether it's turbinate reductions.
Tetracaine ointment. Okay. Arif?
Specifically for sinus, I'm going to say advanced utility of the microdebrider blades on a drill setting, like described for concha bullosa work or for any kind of bony work that you want to do without...
So rather than doing the oscillating mode, you switch to the drill mode, and it's a one-way rotation, and you found that's been an interesting opportunity for taking down bone.
Correct, and
Okay.
it requires a little bit more expansion, but yes, that would be a short answer.
Jivian?
Probably, I guess this would be 2 or 3 years ago, the high-speed burr, the 30K M5, that's really facilitated a lot of the drill outs.
For the more advanced skull-based work, sphenoid rostrum, things like that, you found it effective. Excellent. Kevin? You're looking happy now. I'm happy. That's great.
I'd have to, I'd have to say the Propel Contour. I honestly am not a big fan of the other two, but this one seems to be just contoured the right way to fit into the frontal sinus. And whereas before I always felt like they got crusty and I had to pull out these Propels or these minis, and I think I have noticed a difference in my frontal sinus outcomes over time.
Good. Greg?
I was going to say the high-speed drills as well, but the second thing I was going to say, since I can't, since my teammate already did, the Hoseman frontal punch, we just got it a couple years ago. I love it. My fellow loves it. She's smiling right now. She knows it. It's just a great instrument, and it's super cheap and reusable.
Well, the correct answer is, because I don't have one yet, is the Hoseman. So that was actually the right answer, because I don't, I don't have one yet. So now, what's the score now? I think it's 2-2. So this is the last question. This is the best panel I've ever been on. It's probably because of this cool... Okay, all right. So anyway, thank you very much to our awesome panelists, Greg, Jivian, Arif, Kevin. Thank you, David, for stepping in. And thank you all for being here today. Special thanks to Ian and Greg. Having had the good fortune of having put together some sinus courses in my career, I recognize the extraordinary amount of work it takes to coordinate the CME, the vendors, all the guest speakers, and I really want to celebrate and honor the two of you for the continued work to do to ensure that we can continue educating ourselves. So thank you very much to the two of you, and hope you guys enjoy the rest of your meeting. Thank you, guys.